Hello everybody, and thank you for joining us this evening on the second question time. I'm here together with Dr. Dominic O'Hooley, Dr. Peter Fairburn, Dr. Michael Ainsworth and Dr. Wasim Faisal. Tonight we'll be talking about handling and stability. We'll be going through some pre-asked questions from some doctors, and also if you want to ask any live questions, please type them in the right hand side drop box. Unfortunately, we have to mute all our attendees just because we have too many people to all be talking at the same time. But please interact with the question box throughout the question time. So hello to everyone that's joining us today. We'll move straight on to the first question. So the first question, how long does EthOss take to set completely after placement? And which elements in the product make it set? I'll pass this on to Peter.
Right, hi, thanks. Firstly, I'd like to say I've just looked at that video and it's terrible what's happened in Beirut. So my sympathies to everyone who is involved and all the friends I have in Beirut. It really does look disastrous. Anyway, on to EthOss. Well, it takes 3 to 5 minutes, but it actually takes up to 20 minutes to completely set. And this is the process of calcium sulfate and of the early enucleation phase and then crystallization. So to make it set faster, I'll show a video later when we talk about wet and dry and how to make it set faster. And yes, it is the calcium sulfate element in the product that makes it set. Look, the whole thing is that the stability doesn't just come from a hard set. So if it's not that hard or blood gets in it, just put the suction down, get the nurse to hold a gauze. And the stability also comes from the way that the particles interlink, especially the BDTCP particles. So it's not just the hard set. So if you don't get a rock hard set, it's really not going to make much difference. Anyone else?
I mean, Pete, I'd agree with that. From the years of using it, my feeling is that I'm more than happy to suture when it's like a stiff putty-like material rather than a hard, rigid set. And I feel that the second thing you mentioned, the beta tricalcium phosphate granules interlinking, I think that's a key factor of it for me. And I'm confident and comfortable. I don't feel concerned that I'm going to have washout or it's going to be lost. But I think that's a little bit different than just trying to suture over it when it hasn't set at all. That's very different. And I think that's part of getting used to the material and understanding the phases that it goes through during that initial set and then the more prolonged phase.
Yeah, I think another element to that whole process is the management of your flap. So you need to be relieving and looking at your tension-free element before you really get going, because what you don't want to do is have your material in place, have it basically set, and then realize that your flap's at half mast, if you like, and then you need to go back in and relieve your flaps some more, and then that will create a lot of extra bleeding, which may actually sort of reverse the set and cause you a little bit of washout. And then pressure at the end after you've closed as well will help it set once everything is closed. So that's another important element to stability, is actually having the patients to just sit there once everything's closed with a gauze, gently pressing on it.
And the only other thing I'd add, and I think Pete said it, was the mix. You've got to get the mix right, basically, and decide, because if you, most often whenever someone said to me, oh, it's EthOss, I've had this or that, it's usually they haven't actually mixed it in the right sort of way, and it doesn't sort of reach the right sort of set that you want. So it'll make life very difficult for you. So if you follow the sort of protocol, it will mix really well, and you'll actually get a really nice result with it.
Brilliant, thank you for that. We'll move on to the next question. How set is the material before you start the suture closed? Also, when beginning to suture, sometimes bleeding can start to penetrate the ethos. Do you then replace the gauze, or do you just suture close knowing it will set as previously?
Yeah, again, this is the situation is that I've often had cases that have bled a lot, and I had a great result with them. So the key is to actually get your nurse to put the suction down and to do everything with gauze. And so she can help control it by dabbing the sides while you're suturing, and then just holding the gauze over. If it really starts to bleed, just hold the gauze for a few minutes, and then it will subside. But it will start again. Some people, especially, I mean, you know, there's a lot more usage of these new anti-clotting, you know, clopidogrel, things like that, Rexaban. So basically, we do get a lot of patients in that age group, because now everyone gets put on, you know, once you get to 60, 65, they just give them out like Smarties. So you find that you do get a lot more bleeding in patients now than you used to. And it's, so yeah, that's it. Leave it up to the nurse to control it. And don't worry, it doesn't seem to affect the result in most cases, you know, so I'm not worried about that too much myself on a day-to-day basis.
I think just adding on to that, I think that I personally worry if I have a case that doesn't bleed. There's nothing worse than the dry ivory bone of the patient who doesn't bleed. You know you're on a loser from day one. So for me, a good healthy amount of bleeding is something that makes me feel I'm going to have a good outcome in the first place, because you've got plenty of, you know, vascularity at the site. The second thing is, I notice when I place EthOss, sometimes I do get a bit of increased bleeding immediately after placement, and that can happen as well. And the key there is to do just as Pete said, which is keep you cool and don't just reach for the high volume aspirator with the small tip, because if you do that, you will evacuate some of your EthOss, and there's no reason to do that. I think what Pete said is, have your nurse with gauze there ready and use your gauze, and you'll find that it controls it really well. And take your time and realize that, you know, you've all the time in the world here. Usually you find when you start doing implant surgery, you can find you're trying to rush your way through it and get it finished because you're in a state of heightened anxiety because you're doing something that's a bit outside your comfort zone. But instead of that, sometimes it's better to actually take a breath and realize that if you think about every part of the case that you're doing, you'll have a better outcome. So it's a good time to reflect on the next phase while you're waiting for the EthOss to set.
Yeah, patience is the key. In terms of how set the material is before you start suturing closed, in the old days we were using EthOss Vital, and we were sometimes mixing bond bone, which is pure calcium sulfate, into it to make it really, really set like rock. I think with EthOss, you don't actually aim to get it set like rock. It's almost a little bit sort of spongy, you know, almost like concrete that's kind of setting, if you know what I mean. It's like that sort of sponginess, like you can put your finger into it, that kind of thing. And that's where you want to be, because especially if there's a little bit of blood about, there's a little bit of fibrin clot happening, you're getting a little bit of you know, the good stuff actually into your graft right at the start. And yeah, you've got to remember that the geometry of the particles are, that's the thing that's on your side with this. So it's not just going to crumble because the particles are very interlocking, basically.
I think you've hit the nail on the head there, Mike, really. Yeah.
Thank you for that.
Yeah, no, I just was going to say the same, exactly what Dom said, actually. I like bleeding. Bleeding is good because with vascularization, you get success. And I think that's in all forms of implant dentistry, general surgical principles, but good vascularization means better outcome as well.
Yeah.
Another thing we've got to really look at, which Dr. Ram from Malaysia pointed out in a way, is sometimes the syringes, especially if they've flown a long way, you may actually get more of the beta TCP and settling further up and more calcium sulfate on the surface, So if you're mixing in the syringe, you sometimes get a point where you're going to flood it, over flood it, and then you're going to, when you're drawing it out, you're taking more of the calcium sulfate out into the actual gauze, and that can be a problem. So really making sure that the product is mixed in the syringe, or I often mix it outside in a dappen dish, and that's a better way of actually making sure you retain the calcium sulfate element, because that's something that can happen.
I mean, that's, again, coming back from the vital days, that's how I tend to do it, actually. I sort of tip out, and I do it in stages as well. That's the other thing. Rather than just sticking a whole massive big block in, just mix a little bit of it, keep a little bit to one side, and just pop that in, let that go off. Quite often you'll do that whilst you're putting your implant in, so you may want to actually give the implant a bit of a bed as well. And then as that goes off, you can dab that and then do a second build. And the remainder that you have in the dappen dish will actually help set more rapidly the next lot that you put in.
Yeah. I find that what I tend to do is slightly free the syringe first before I take the top off, and tap it, and almost, because when you've got a long flight on your EthOss, it's going across to the Middle East or wherever else, and it's become slightly, the particles have become separated with calcium sulfate at one end and your beta tricalcium phosphate at the other. Just vibrate the tube when there's space in it, and you'll get it remixed together again, and then you can mix it in the tube. And to be honest, I'm a little bit different than you and Mike and Pete here. I tend not to mix it in a dappens dish, but I think that's a good alternate technique as well. What about you, Azim? What do you do? Do you tend to?
No, so in the previous webinar I just showed how I mix it in the actual syringe, and I do exactly what you do, Dom, that you flick it at the top first just to free up the particles a bit more, take off the top, and then you add, and then you really give it a good mix, basically. And then when you, and the other thing is when you expunge it, don't try and expunge it too quickly, just gradual pressure against the gauze, and that really sort of gets that right sort of mix. That's why I find as well works really well in my hands, actually. But I suspect you probably, if you're doing a wet mix, you probably need to split it into two sections. So you probably expunge it, do a slightly wetter mix initially, and then you take the remaining out and do a drier mix, I would imagine.
Yeah.
So
we'll go through that in a minute. So wet, dry mix. I've just got a video, I'll go through the video a little bit and we can have a look and see.
We'll come to a question on that later. So moving on to the next question. Could you explain a bit more about the tenting and using it with meshes? When do you decide to do this? The tenting with the PDS 2.0 sutures, and please elaborate the type, technique, and when and how, in which situations place the tenting sutures. I'll pass this on to you, Mike.
Yep. The main reason is when you think that you're going to have slump. So, for example, if you have a thin ridge and you're basically placing your implants and you've got exposed threads, maybe you've got a couple of implants together, and it's a vertical ridge and there's not a wall either above or either side of it, it's just literally you're just wanting to add out, then that's where tenting really helps, and it acts basically like the catch netting on an alpine roof that keeps the snow on. That's how it works. They've got those little ridges, and that's literally what it is, and it just stops the material slumping, and that's when you would use it, or when you are putting an implant outside the bony envelope. I've got a little case to show of that sort of thing. If you want to put that on.
I'll pass you the screen, Mike.
Okay. Yeah. Can you see me? So
if you just click the share screen button, there we go.
Is that working? Yeah. So this is a case that we saw, and there's a very large cystic lesion on upper central incisor. And as you can see, it's through and through. It's also eaten away the palatal bone, and really you've just got the alveolus holding the adjacent teeth in that's present once this tooth's taken out. There's no apical bone, there's no buccal bone, and there's no palatal bone. So in this situation, we had to oversize the dental implant and place it to engage in the lateral, the mesial where the lateral is, and the distal where the central is, in the mid-third. And so the first thing that you would do is do a frenectomy in this area. So you always need to think about muscle pulls, because when you're going to be tenting is generally going to be in places that are going to be very, very sensitive to any muscle pulls on your flap. So always look for that first. And we raised this and found the defect. And then this was a sort of minimally invasive zero prep case. And you can see this is the final drill, and we just laid it in. So the threads of the implant were really only engaging mesially and distally in the middle third. And obviously you can see that this implant was of a suboptimal diameter for the area, and it was going to sit outside the bony envelope. So in this case, this is where the tenting's used. It's there to just, well, tent the flap up and provide a space, and then you flow a wet mix underneath, and then a dry mix over the top. Make sure it's set, and then suture as you normally would. And this is the sort of situation you get when you uncover the implant. And so we get quite an adequate volume of tissue. And this is what it looks like a year later. And I think that's a pretty adequate result. And then this is a couple of years follow-up. And you can see it's been in function because he's cracked the incisal edge off. So, and that's stable. And it's a case that I'm not sure I could have done as simply without tenting and as predictably. So that's one of the places that you would use that that technique. So
brilliant, thank you. Has anyone else got anything to add to that?
Yeah, that's a nice long term. Yeah, I've been doing more and more cases, and been enjoying some of the results in very difficult situations with tenting. And so yeah, I see there's more and more value. There's a lot of mesh cases being posted as well. The problem with meshes is that there's a risk that they can expose, and in the wrong situation. And that's the difficulty. If you're going to use a mesh, then try and put as much EthOss over the top. That seems to help reduce the chances of exposure. But I'm just doing some right now, and I'm just trying out new type of mesh. So we're going to see what the results look like.
I think purely anecdotally, I think I found with meshes you tend to get more wound dehiscence, whereas with tenting you get less. So that's one of my anecdotal findings. I can't say scientifically, but that's what I found with meshes. So I prefer tenting as well.
Dom, have you got anything to add to that?
Very little to add, really, because I've tended to tried, I haven't actually used the suture tenting technique to date, and that makes me feel rather ashamed, because I should have. I think there's been a couple of cases where I'd have benefited from it greatly. I've tended to rely on doing secondary placement when I come to uncovering, and I think that sometimes I'd have been better off actually using the tenting technique in the primary build, and I may not have needed to then go back and do that secondary build. So I think it's a learning point for me, and I'm happy to hold my hand up metaphorically and really and say that it's something I need to get myself doing more, because I think it's a great technique. And I'm not just being nice to Mike here.
Right, moving on to the next question. Do we need to stabilize the adjacent tooth that comes with a deep pocket? If deficient implant site and the adjacent tooth is grafted at the same time, how do you stabilize a grafted tooth that is mobile, and how do you keep the place graft dry before it sets? I'll put that to you first, Wasim.
Yeah, interesting question. So from my point of view, with looking at the first part, if it comes with a deep pocket, we need to know, is this primary disease stable or not stable? So I would always say we need to stabilize any primary disease, whether it's debridement, etc. If it is stable, then I would put the deficient implant site and adjacent tooth. Yes, I would graft it, but the point is, I need to know more. Why there's a deep pocket? Is it unstable primary disease or stable primary disease? Any thoughts on that, gentlemen?
Yeah, I agree. With anything you're doing, you've got to look at the etiology first and try and overcome it. But the odd thing about stability and splinting is that I've completely not splintered a number of grade 3, really mobile teeth. And I've been surprised that 3 to 4 months later, they actually completely stable again. And this goes back to the Vital days, where they did a study where they used Vital on a rabbit, on its spine, and fused its spine while it was hopping around. So, but I like the idea of splitting. Some of the big cases that I do, say cases, I've got 10, 12-year follow-up on cases which were sent for all on force. So all of the upper arch was very mobile. I then splint some of the teeth by using a Tempe bridge and place implants and graft in between, and they've lasted 10 years, 12 years. But as I say, there have been cases where I haven't stabilized the grafted tooth, and 2 of which I've just published recently, and they seem to work pretty well as well. So it's one of those areas, there's a lot of research in it, and we're about to start off a whole lot of perio research at the moment to try and learn more about why we get results.
I think there's a great deal of value in actually the occlusal splint, because quite often the exacerbating factor where you do have these quite, the ones that are amenable, the narrow, steep, and deep infrabony defects that affect certain teeth, rather than a more horizontal effect. Quite often you'll find that the main exacerbating factor is a fremitus or an excursive contact somewhere. And so I think you don't necessarily need to splint them rigidly, but have the patient wear a well set up Michigan or Tanner will actually really help, and it will really help with a lot of things in those cases, I would say. What do you think, Wasim?
Yeah, I think I agree, and I think you're quite right in that occlusion plays a major etiological factor in this. And I think exactly what I was saying, that we need to establish the etiological factor, what's causing it. So if that's been eliminated, then you wouldn't need to necessarily splint it necessarily, but you could graft it at the same time.
Mike, 2 Penny there, that I haven't got much to say. I'm extremely limited experience at treating perio defects at the same time as placing implants using EthOss. So, but I think it's a very interesting area for further research, and it was nice to hear that Pete's saying that there is research going on in this area. It interests me that there does appear to be anecdotal evidence of quite interesting results with regard to stabilization and improved support of these teeth. So to me, it's something where further investigation is required, but I can't give you my own personal experiences with it, I'm afraid.
Yeah, I was once involved in a panel debate about 8-9 years ago at Zurich University, and oddly enough, I was the interloper, being non-German or Swiss German, and I was the only one who said that occlusion or malocclusion or it can have an effect on bone loss. It was frowned upon at the university. It was all about bacteria. You know, but I do agree that actually correcting the occlusal difference, you know, how often you see a patient coming with a mobile central and you put your finger on, you tell them to tap together, what's it doing? It's hitting the central. You correct that, that's going a long way, but they completely disagree at Zurich University Department of Perio. So, you know, that's an interesting thing, that's all.
And also the effect it has, I mean, going off topic slightly, but on the stress resistance of an implant as well, with the occlusion as well. So it's a massive importance actually, because I did my whole thesis on this, which was took me a long time, but yes, it was on screw fractures and screw loosening basically, and one of the factors, well, major factor was occlusion. So
yeah, it's often forgotten because especially in implants, occlusion I feel plays a bigger part than because of the lack of I mean the rigidity and the osseointegration. So you need to get things far better then. What do you guys think about just an idea on cantilevers and cantilevers on implants over cantilevers on natural teeth, say a 4 holding a 5 or 5 holding a 4?
I'm more of a fan of a canine holding a lateral or a central holding a lateral. I think you've got to be a little bit careful, though sometimes you can cantilever mesially off an inclined implant. So I sometimes steal a little bit of space, especially in the upper, if you run an implant down the medial wall of the antrum and the sinus, and sort of gain a little bit of space there, and then mesially cantilever off that implant. But I would tend to try and reduce the functional loading of the cantilever as much as I possibly could, and have it all going through the actual fixture.
I did
We
an
won't talk
interesting
about your
case.
case.
Well, I was going to mention my case. Interestingly, perhaps pushing the boundaries a little bit with regard to using, this was a case that was referred to me where a gentleman had had an implant for 8 or 9 years, a lateral with a central cantilever, and it appeared to have suddenly failed. I'm afraid I didn't have the radiographs from the referral to see whether that was a sudden overloading failure or not. But yes, I've used an inverter implant with an EthOss build and cantilevered, used the initial permanent bridge as a provisional. And I've had some mixed responses from posting the case, but I think it's going to be a real learning experience for us all. To me, I've done everything I can to balance his occlusion, but I'm well aware of the fact that it's impossible to do that entirely with that kind of fairly aggressive protocol that I've used. But I'm going to continue posting the reviews of that case, good or bad.
Yeah, because
and that's a promise online here, so I can't go back on it now.
Yeah. I mean, what about the difference between sort of men and women generally is, I think women are much more an easier case to use cantilevers in a way where men seem to be a lot more brutal on the occlusion, maybe the stress. I'm not sure.
I think the brachiocephalic skull type is more common in men with the big masseters and the skull that's almost like a Rubik cube with all the muscle tone around the jaw. Whereas the woman with the more aquiline features and the rather delicate masseters and bussinators. So, you know, that's probably incredibly sexist, and I'm probably going to be what's the latest word for it? Cancelled. I'm going to be cancelled.
Cancelled, yes. We'll have to cancel Dom.
I think we'd
Anyway.
all get cancelled, to be honest.
Should we move on to the next one then?
I
How do you
think
keep
I'm
it
still
dry?
sharing my screen.
That keeping it dry before it sets is just, it really is about learning to work with your nurse and for her to understand what you're doing. So you're working as a team. And in that way, you know, you change your protocols. And I guess I forget, because I've been doing it every day for so many years, that you just change ways of working with things. And so, you know, I use my nurse a lot in helping me control the grafting and keeping things dry. So they got to understand more of what you're trying to achieve. Right, should we, Joe, next one?
Moving on. For cases where there is insufficient bone volume, it can be a struggle to place the implant and the EthOss while trying to obtain closure of the flap without tension. Can the panel give some guidance, any guidance on this situation? I'll pass that to you first, Peter.
Yeah, well, here again, this is quite, especially on the upper. Just start the incision more from the palate and take the incision away. And on the lower, I start more lingually. And if you leave it open a little bit, it doesn't make a difference. It'll heal by secondary intention. And I showed that at the last question time, where literally 4 or 5 days afterwards, you've got healing by secondary intention. The only problem with this is people who are heavy smokers or uncontrolled diabetics. So those are the only two you've got to really watch out for. And by doing a technique as well, you're effectively shifting more keratinized tissue, slightly more buccally. So, you know, I do that a lot. If you can, I know it's a difficult incision. I start on the palate with a split thickness, then going to a full thickness. So you end up with a better healing situation there. But again, I'm using more and more narrower implants now. You know, people talk about implants breaking, but I've been doing it for 30 years now, and I've had about 5 or 6 break, and a lot of them have been really good accidents, like skied into a tree or something like that, which you can't really. So I don't really have that real problem with implants breaking. You know, when I say narrow, I'm talking about 3.5, 3.75, that sort of range.
I'm glad you said that, Pete.
Yeah.
I'm glad you said that, because that was exactly the findings I had as well. And in my master thesis research, it said that provided it's an internal connection, the diameter 3.5 will function as well. You know, and it's not, you're not going to have any, it's not a significant risk, etc. So.
Yeah.
But people often glare at me when I say that, so I have to say it with a bit of, you know, hesitation.
As long as you don't get cancelled.
I know. I got shot down once on Facebook for suggesting that. So I just thought, okay, well, you know.
Yeah, there's always heroes out there.
I think there's a difference between doing adequate periosteal release and making sure that you've got tension free, but you do get cases where you have a real tissue deficit. And I think it's all to do with prior planning with your patient and being very clear with the patient that you've got this very difficult situation. And I think secondly, for me, using the implant in a transmucosal approach is giving you tissue, because remember, you've got that implant healing cap volume that you don't have to replace with your flap, if you see what I mean, because you're kind of suturing around it. And I know that sounds like it's minimal, but it's some tissue. And thirdly, I often do leave EthOss exposed. I'm sure you've all seen that on my cases. And I find I get fast epithelialization across the EthOss. So as long as I'm being quite selective with my cases, as Pete mentioned at the beginning, this isn't appropriate for 2 main groups, heavy smokers and people who are uncontrolled diabetics. But I'd add a 3rd group to that, and that's people who don't follow your instructions very well. So people who, so people who are fiddlers, who go home and start playing with it with the tongue, getting the toothbrush in it, getting a cotton bud out, thinking, oh, I better keep it clean, I'll give it a good old brush. These are the people that I wouldn't leave exposed EthOss with. But in many of the cases I do leave it, and I seem to get in my hands at the moment, and for quite a while now, I appear to be getting quite predictable results. I'm not sure it's definitely not within the EthOss protocol. It's a sort of like a outlier technique that I do.
Yeah, generally the whole thing is about your own personal skills as well. This is a very wide thing, and your understanding of patients, you know, that, and that's what I always say in all my lectures. It's about, you know, any grafting material is about understanding good surgery and understanding the biology of what you're trying to achieve. Once you do that, it becomes easier and easier. Mike?
Yeah, I think it comes down to the delicacy of the flap design. I think quite often a two-sided flap is still the way to go. I know people will disagree, but I think certainly on a single site, if you've lost quite a lot of bone, if you are careful with the incisions you make, preserve the papillas either side, and flare your flap out, you can get it really. You can get a lot of release of the flap without even starting to release it in a periosteal way. And then quite often people, certainly who are beginning to do implants, are a little bit too tentative with firstly the reflection. So they reflect a lot less than they should do, and then they try and relieve that halfway down, where if they just are a little bit more confident getting in and relieving the flap and getting it off the bone, they'll find that it'll be a lot looser. And then the periosteal release that comes after that, there's a bit of tentativeness about releasing that as well, and how deep you need to go sometimes. But you can release most flaps, I would say. It's very rare that there's so much scarring and problems that you can't get a good release on a flap.
What about sometimes you can get granulation tissue on the inside of the inside of the flap, on the periosteal surface, and also, you know, occasionally I've scored the surface just with 1 or 2 cuts, and it lets, you know, and then people say worry too much about the periosteum, but it does heal very quickly, and that allows more flexibility in the flap that you do have. But, you know, often you notice that even in 3 to 4 weeks, the flap is healed into the socket site in a significant amount. So you need to separate that, clean that a little bit as well. But again, it's case to case. So, you know, that might be something that people might see.
I think also just to add, suture technique and how to close it up as well is really, really important, actually. I think, Mike, you talked in one of your presentations about how people often make the mistake of going from the crest or down, as opposed to closing up. So,
I think one of the most important things, I think one of the most important things is pulling the flap up to start with. So instead of do your relieving incisions, and this is why having 2 relieving incisions is so important. And you pull the flap and take the tension off the ridge before you start suturing the ridge, and that, I mean, that Peter taught me that, you know, back in the day, and it served me very, very well. And I think that technique of just bringing everything up with the closure of the relieving incisions makes your life so much easier, because you can do that, and it gets a lot of your bleeding out of the way dealing with the relieving incisions first, because then you can pat the flap down and it'll sit there static, and then you can be very delicate about closing the rest of it up.
Yeah,
I think
another thing, you know, just...
Oh, sorry, Pete.
No,
go ahead.
No?
I was just going to say, one of the things there is if you've got a high smile line case and you do have quite a noticeable transition between your keratinized and your non-keratinized mucosa, be a little bit careful with regard to a discrepancy in your keratinized level if you do that too much by hoiking your flap up kind of thing with the relieving incisions. And secondly, also about scarring. I think an alternate technique I like is to not do 2 relieving incisions, do 1, and use a large triangular flap. with only one release, but make it large. So it still stretches, but it just does it in a slightly different way. But it's just, I think it's horses for courses and what works in your hands. So I don't think that there's one prescriptive way that you should do it, but I think that it's the methods that you learn and work better in your hands.
And also, the one caveat is that if you know that you've got a big defect, don't do a site-specific gap flap. Extend, basics. It's basic surgery, but sometimes you can get caught out, and especially if the defect's bigger than you thought it was, and that's where pre-diagnostic 3-dimensional radiography comes in really useful here. But I think extending your flap, if you're a bit worried about it, is definitely the way forward. And sometimes it's better just to do a bit of a smaller flap with no relief to start with, and then just kind of see where you're at on the site, and then extend as you need to. And also it depends on what's next door as well.
Yeah, just to anecdotally say that what I've noticed with EthOss is that I don't have a correlation between flap size and post-operative discomfort. So, I do fairly juicy flaps, fairly meaty, non-site specific flaps quite a lot. And I'm finding with EthOss, and this is anecdotal and it's my experience, that I'm getting very minimal reports of post-operative discomfort from patients. And it makes me wonder whether the material itself is having an amelioratory function with regard to the post-operative pain, whether it's the fact it's bacteriostatic, whether there's other things going on. But it's made me, over the years of using it, it's made me far less concerned that by doing a bigger flap, I'm going to create a more morbid situation for the patient in the days post-operatively. Doesn't seem to be an issue. So I don't know if any of the other guys feel the same there.
Yeah, I agree.
Yeah.
Should we get on to the next one, Joe? Because I'm not sure how many more we've got.
Yeah. Just to add, if anyone does have any live questions, please do type them in the question box on the right-hand side. We'll try to get through as many as possible. So what is the difference between a wet and dry mix?
I'll answer this. Well, one's wet and the other one's dry.
I was thinking that, but I was waiting.
That's just me being facetious.
Right, Joe, do you want to put the video up and then I can talk it through?
Yeah, let me just share my screen.
Just the mixing video.
Bear with me 1 second.
I mean, effectively, you can do a wet and a dry mix through by just taking less compression out. But here, I'm just showing on a demonstration model ways of actually using Dappen dishes and to mix out of the syringe, to mix a wetter mix. And what I'm doing, you see, loosening the material here. So mixing it up enough. And then, I know it's a bit slow, static, the video. And then I'm going to actually take half of the mix out, half of the material out. Can you see? Place it in the Dappen dish. And then I'll make a slightly wetter mix here, because this is now going to go deeper. So this would be when you're placing around an implant or just wanting to fill a deeper site. And a drier mix will be used more on the surface. If you want to restrict the amount of saline you're using, just place it onto an instrument. And in that way, you can see I've already put too much in. And then we effectively can make a wetter mix. Can you see that's very wet? So I just take a little bit out and make it a little more solid. And then we're going to place this. You can make it really wet to the point that it actually is flowable in. But in here, I'm doing effectively a socket graft. So we're going to use this as place on deeper. Now, to get a drier mix and to get it when we've actually let it set, do you see the remainder in the bowl that's actually set? Not in there, but in the bowl. That becomes a dihydrate after about 15, 20 minutes, and or the calcium sulfate element does. So by mixing it with fresh material, you've actually reduced the amount of hemihydrate. So it'll actually set faster, and a lot of the material will go straight to crystallization phase. And so it helps bypass the enucleation phase of the calcium sulfate. And by doing it like this, when we just do a small amount, you can make a really dry mix, which you can then use to build out Buckley or in a more complex situation. And by actually making it incredibly dry, by mixing the minimum amount of saline as well, I think I overused the saline a little bit here. But if we mix with very small amounts of saline, can you see by just doing drops off, yeah, I overplaced it a little bit too much. We end up with a very dry mix that actually literally sticks to your instrument. So you'll see, I just add a little more to just get it even drier. And when we end up with this very dry mix, it actually becomes quite sticky. So I'll show you in a minute. When we put it on the instrument, I just push it on so that you can see it's stuck to my glove. You can see we can hold the instrument upside down and the material won't come off. And then this allows us to have more of a handling ability. So say, for example, when we're building onto the buckle aspect. And sorry, it's really jumping around the video. But then when we hold, can you see the kind of a much drier mix? And then when you hold that for a few minutes now, because it's already got some dihydrate in, this allows it to set even faster and harder if you want that. Okay, and so you can see within 4 or 5 minutes outside the mouth, you can tap it, and it gives like a solid sound literally. So that should be fine. All right, Pete, should we move on and we can just debate that really? I know the video did jump around a bit. Yeah, Dom?
I mean, I'd agree with you. It's given me food for thought, to be honest, because as I said earlier in the presentation, I tend to be the tube guru in a way. So I just use the EthOss in the tube. I've been very recalcitrant at using a DAP and spot, primarily because the one time I did try it, I overhydrated it. And then you're kind of in a position where you're either having to wait longer or add more. And so I think that video I've just seen, which is the second time I've seen it now, it's just brought into my mind the real importance to be very judicious with how much saline you're adding. So important to do that. But it's good that
yeah, sorry, Dom.
No, I was just going to say the other thing that was interesting is the way that the material does stick to your instrument when you do the dry mix. I've noticed that as well. And it becomes almost tacky. And I think it's a really good learning point that if you're using the DAP and spot and you leave your anhydrous material within the pot after you finished using it, you will get a faster setting time with your second tranche of material. So yeah, thought that was useful.
Yeah. The other thing is if you flood it too much and are drawing out too much, you're taking actually more of the calcium sulfate out of the mix. So, if you want a harder, faster, or better setting, then, keep it like that, with a minimum of saline. Any other comments, Mike? I know, Mike, you're probably used to doing it that way from the old Vital days. Where you got the little tub with it.
Yeah, you got the little tub with it. And it acts a bit like the nucleation agent. And it's just, I've always really done it in 2 stages. And with us going back to the tenting, it makes the tenting a lot easier because you can flow a mix underneath and it's not going to pop your sutures out, and then just gently tap that, and then your dry mix goes over the top of that. And I find myself modifying the consistency of the mix, and there's a middle ground that I use quite a lot as well. If I'm just putting it on in one, I don't use a wet or a dry mix, if you like. I go somewhere in the middle, And but again, I think using it in different methodologies. For example, if you're going to put it up into a sinus, again, I would start off with a relatively dry mix, but it turns into a wet mix when you're actually pumping it up into the sinus. So you start with a dry mix and then it goes wet, because you can never really keep those sites completely dry anyway. So so certainly with denser burrs, it's very useful to have that property of the material, I find.
Yeah, the dry mix is.
Regarding rotation speed of denser, when you're doing that counterclockwise pumping motion to create the crystal lift with your EthOss, I know me and Pete were discussing this the other day about the rotation speed we're using, and you know, you can go as low as 25 revs a minute, and you can go a lot higher than that as well. What were you using, Pete? Just remind me.
200.
200.
Wow.
Yeah,
I use about 50. I do mine at about 50.
Oddly enough, I think 200 is what Costa was saying, and I think Salah says that.
I think also the slower the better, because you reduce the amount of dead zone that you create with osteodensifying as well, because otherwise you need to go back in with the cutting burr to remove the dead zone as well, right? So I think the slower the speed, the better the reduction of the dead zone.
Yeah.
Yeah, I think I'll start slowing it down a little bit.
I mean, I really like the case you put up today, or maybe it was yesterday. It's a lovely little lift you did there, Pete.
Yeah, I mean, the custom denser does just give you. I mean, I find it very hard. Obviously, you can't use it on the lower. You know, the expansion story is neither here nor there. I think you get just as good an expansion on the upper arch, especially by just using the implants and under drilling, especially with any ridge. But you know, the expansion of is not so, but it's a fantastic tool for, as you say, just doing a quick lift like that. It's great.
I disagree with you on the expansion. I find it very useful for expansion.
Oh yeah.
But I think you probably hit the nail on the head there, that I think you're using the AnyRidge implant, which is particularly effective for expansion, isn't it?
Yeah.
I think it's an implant specific thing. I think if you get the right implant, you can expand very well with that implant. Certain other implants are less effective for that. But yeah, again, it's I think it's because I've got the gold first, so that it's better for that.
Yeah.
I mean, the whole idea of Mukesh always talks about it, about bone manipulation. I mean, it is a lot of, it's a tactile thing in a way, and you learn it with time. Don't you agree, Wasim?
Yes, so just to come back to the Versa side of things, basically, I'm with Dom. I do agree with this. I find the expansion side of things very, very useful as well, actually. But it's, the only thing I would say is that when you're using it, it's not, you can't just rely on Versa on its own. Basically, you got to know the bone, you got to know the situation you're in, etc. So, like I use Neodent GM, and I find that is the Helix. You can under prepare with that, and you can expand really well with it. But it's a lot easier when I use the Versa burr, basically. So that's just my opinion, basically. That
the other great thing about the Versa burr that I've found is guidance. So when you have tight sites and you've again, say you're doing an all-on-4 type case, where you've got to run an implant up the medial wall of the sinus, you can just do a lance burr and non-side cutting, and then just expand from there, and it'll just guide you straight up that wall. So it works really, really nicely for those sort of things. But we're digressing slightly, really, aren't we?
Yeah, I think let's move on to the next question, Joe, because I suddenly realised time is moving on.
We've got a question, a live question actually, Peter, just to go alongside that. Nick Spilker has asked, do you lose calcium sulfate if the mix is too wet and you have to draw saline out with a gauze.
Yes.
Yeah, you can. Definitely you can lose some, yeah. Whether it makes that much difference, I'm not so sure. I mean, the calcium sulfate there has its role, but its role is only 3 to 4 weeks, and it's generally gone. But those 3 to 4 weeks, I think, are a critical time. And this has been the problem in the past, is by using membranes and other protocols, you're taking away the most critical time for bone healing is at that really initial phase. And this is what it allows us to do, is to optimize those really early healing phases. That's why even when I show cases at 6 weeks, we're quite surprised how that there's new bone formation even at 6 weeks, osteoid, early bone formation.
Yeah. Right, we'll move on to the next question before we go on to the live questions. One of the times I used EthOss, I got an allergic type reaction from the patient. Is that common? I'll pass that to you first, Dom, if you've ever had that problem. Dom seems to have gone. I'll pass that on to you, Peter.
Yeah, I've never heard of it. I mean, I've never really had that reaction, but as you say, there's always some possibility of that. I've just never heard of it, never seen it myself, but everything's possible in this life. Wazim, any issues?
I was just thinking about it. Never once. Ever an issue. In fact, more people take up EthOss because I've had more people coming to me not wanting animal products, etc. So the uptake is higher, but I've never had anyone have an allergic reaction to it ever. So
yeah.
I mean, there's no giant cell reaction when we look at things. Histologically, we've had a look at studies and we never seen any giant cell presence there. So.
I have had problems with the use of Vicryl though, so that might be a confounder. So if people are closing up with Vicryl, I have had people who've had all sorts of pain and problems, and then as soon as, literally, the minute you take those stitches out, gone. So it may be that there's some confounding factor there that's not actually the graft material at all.
That's interesting.
Yeah. Should we move on to the next, Joe?
Yeah, we'll move on to the next question.
What's happening with Dom? That's the question.
He seems to have muted himself.
Yeah, Dom, you've muted yourself somehow.
I didn't mute myself. It just seemed to happen. Oh, that's what I'm saying.
I was going to say.
So God's
you've been
telling you
cancelled.
something.
You were cancelled.
Yeah.
Right. Okay, how does this allow for bone-forming cells and not gingival cells to infiltrate the matrix? The whole idea of gingival cells growing down, there is no real research on this, oddly enough. I mean, I know it's a complex one, but I think that the soft tissue that was seen when people were using xenografts and it was encapsulating is threefold. I think it's the giant cell reaction to a foreign body giant cell reaction leading to enucleation. It's the body trying to protect itself from the cells. Also stability. If a graft's not stable, mesenchymal cells could differentiate fibroblasts, plus the cleaning of the site. I'm not sure how a periosteum grows, infiltrates the matrix. So I think there's other factors really. This is just an easy solution, and it was just a story to make give an answer for what people were seeing without looking at the true reasons of what they were seeing. That's just my opinion.
Yep.
There's not enough research on it, really. That's the strange thing.
Has anybody else got anything to add to that?
I mean, the calcium sulfate, I think, has a big influence. I think the calcium sulfate is a pseudomembrane, and but I think the main factor is the stability of the graft. It just doesn't move, and if something moves in that tissue space, then the body's going to turn around and say, well, this needs to have collagen in it, and so it turns it to collagen. If it's completely rigid and it's in a tissue compartment that is supposed to be bone, bounded by bone and periosteum only, then if it's rigid and it's a matrix and it's semi-permeable, you're going to get osteogenesis, I would say, and I think that would be any. I think that's the main reason.
Yeah, Wasim, have you got anything to add to that?
Nope, I don't. Seems.
Just very briefly, I'd say, just going slightly off topic, is to say that one effect I do see anecdotally with EthOss is upregulation or improvement, enhancement of soft tissue. So I'm not looking at soft tissue penetration of the EthOss per se, but I'm looking at, in my view, improved keratinized soft tissue when I've used EthOss. And so I think that's another very interesting thing, that's sort of a strand that comes off this question, really.
Yeah, I think.
We've all seen that. It's hard to do research on it. So I kind of just say it's a side effect that you get improved keratinized. And it's not just keratinized tissue. Anyone can do free gingival graft, but it's attached. And this is making the big difference. Is somehow we're seeing more like really firmly attached keratinized tissue. And I think this is something that we will, is of great benefit in the long run. It might be just that there's more host bone formation, and so that might help.
I think it's more porous. You get a more porous structure, so you get it, certainly in the posterior mandible. If I've got a big, flat, wide posterior mandible, and I can put an implant straight in, and it's that lovely white bone where your flap just pings off it and disappears like a pair of curtains. I will, and even if it's a massive wide ridge, I will put a fairly significant amount of EthOss over the top of that, and you'll find when you uncover it, it's properly attached, thick tissue, and I think it's to do with how much the periosteum can penetrate and how many pegs it can get into the actual bone itself. Rated pegs, yeah. But those are in cells, aren't they? Rated pegs. Yeah.
You guys having some Yorkshire chat up there?
Yeah, extreme.
You boys from up north. Right, should we get on to the next one? Because that one's.
Yeah, we'll move on to some of the live questions now.
Yeah,
sure. If you haven't answered your predetermined or pre-asked questions, we'll answer them via email and send out to everyone over the next few days. So moving on to the couple of live questions. If anyone's got any more live questions, do ask them in the drop-down box on the right-hand side. You mentioned earlier about granulation tissue on the socket side of the flap. This doctor always finds it difficult to remove it fully and not perforate the flap. Do you have any tips?
Yeah, I kind of just scrape it with the scalpel, rather than cutting it. You can sort of just shave it off, literally. Again, it's a difficult area because every case is different. It's the exciting thing about dentistry. Every day you open up a flap, it's like a box of chocolates. You've got an idea where you're going, but you're always going to have a little surprise, or maybe always have a surprise. But yeah, I agree. Cleaning it can be quite difficult. Sometimes it's quite attached and quite thick.
Sometimes you just got to relieve the flap a little bit more and accept the thickness, and just don't try and thin your flap down too much.
Yeah.
So sometimes you just got to do it the other way around. And if it is that way, then that, to me, that's a big thick flap, which is good keratinized tissue. So it's all good, to be honest with you.
I mean, the amazing thing is the body's ability to heal. Dom, we go back to this all the time.
We do, and that's it. That's the case selection, ensuring your patients have done everything possible before the surgical treatment to be as healthy as possible. So that, and then in the post-operative period as well, that they're eating well, sleeping well, they're not burning the candle at both ends, drinking too much, the rest of it. You've got the right opportunity for good healing. I think going back to the removing granulation tissue from the inside of the flap, I think it's one of those situations where you tend to know when it's the stuff you need to take off. It's got that purple look to it.
Yeah.
It's got that purple kind of hypervascularized, lumpy look to it, and you get rid of it if you can do so easily. I think what Pete was saying, if you're shaving it off easily with the side of the scalpel, but if you're having to really be, it's tenacious and it's not particularly vascularized and it doesn't look particularly like that purple granulation tissue, then do really leave it. I think, as Mike said, leave it. It's part of the flap and it's part of your resilience of the flap. So I think it's a case by case thing. Every case is different.
The only exception, obviously, is if you have previous retrograde endodontics done with some weird or wonderful biomaterial like amalgam, and you really do want to get that out, and that can I would always book a good 15 or 20 minutes extra just to get that sorted. But as with any flap stuff, just to reiterate, always do it at the start of the procedure so that the bleeding happens before you graft. So get that done out of the way, and any perforations repaired before you do anything. Because with the best will in the world, if there is a discharging sinus or something that's been there and you lop that off, you may end up with a dehiscence in your flap. So it's worth
maybe more of a problem.
It's worth repairing that, or seeing if you can do something to repair that at the start of the procedure rather than towards the end, because you can then potentially modify the way that you actually do the procedure to take into account the problems that you've had with the flap. So you might need to change tack on your plan as well.
Yeah.
When
we'll move on to the next question, just so we get through them all in time. So what are the contraindications for EthOss? When would you not use it? Cases which are infected, really large defects, or unable to get good homeostasis. I'll pass it on to you first, Wasim.
Yeah, so if you've got cases which are infected, etc., you follow what I call in my practice the Peter Fairbairn way. You take it out, wait 3 weeks, and you follow that protocol. I'll be very honest with you, a lot of what I do now is immediate work. I haven't come across any situation necessarily where I can say EthOss is a contraindication, in my honest opinion. Yes, if I need to build ridiculously beyond the envelope, then yes, there might be a situation where we need to relook at that. But by and large, for me, EthOss works in 90–95% of cases that I'm working in, and it works pretty well. Beyond the envelope, yes, possibly might be a little bit tricky, but again, I would do it, build up to the envelope where I need, and then review and see how much more I actually need after that. So
absolutely, and people always talk about the posterior mandible as vertical augmentation, and a lot of the people who were big advocates of vertical builds in the posterior mandible are now talking about short implants instead.
Absolutely.
And so with the advent of short implants, you can put implants literally just into the cortical plate, and so you've got to have pretty amazing atrophy not to be able to place a 3 or 4 millimeter length implant into that area, and you just use more implants, I would say, and don't load them. Or if you say doing an all-on-4, you can think outside the box. Quite often, what I would do if I was doing an immediate case is pre-place a couple of implants, wait for them to integrate, and then do the clearance on the other 2 implants, and then fit everything together. That sort of thinking. Whereas where you would have needed a very long implant, a short, fully integrated implant will suffice. And if the ridge is there, use it and nurse what's there. You don't have to do the entire case all in one go, even if you're immediately loading. It's you can stage these things and use shorter and smaller implants. So
I mean, that's a very, that's a really great tip you've just said there, which is something that a lot of people wouldn't laterally think that. That's an Edward de Bono tip, that is. So you're placing your 2 shorter implants prior to doing your clearance and your immediate load and waiting until they're integrated. And then you've got these 2 anchors that are already present. It's a great tip. So thank you for that. It was worth me coming to this webinar now.
Right. Any other questions, Joe?
Yeah, we just got 3 more questions to go through, so we'll get through these quickly. What is the best time to place EthOss in a molar site as a delayed placement, particularly if there's been considerable bone loss or at the time of extraction? I'll pass this to you first, Peter.
Well, again, it just depends on, I mean, I've done all the ways to get predictable outcomes. In all of your cases, I prefer, even if you're going to socket graft, I'm just going to post a really nice one where there's absolutely no bone and I've socket grafted, but again, I leave it for 3 weeks for 2 reasons. If it's massive destruction in there, there's going to be a lot of acute infection. It's better to let the macrophages do a little bit of cleaning up for you. Then you get coverage, you can put it in, you'll maintain your ridge volume, and you'll have a great result. I've started using cervico system a lot just more recently, so placing a lot more immediate if I've got a bifurcation to get primary stability in, and then using the cervico system to, get closure by getting the ideal size. It's quite a clever system. Hopefully he's going to, Ernest's going to bring it more into the UK. I think he is. I'm just trying to arrange something at the moment. And I'm starting to look at areas I haven't looked at in the past. But you want 99% success. This is the problem. The moment you start basically just socket grafting a big infected socket, you become a victim of your patient. They're going to walk out the door, go to the pub, get drunk, wake up in the bath and brush their teeth the next day. So you've got to keep control, and by having some sort of soft tissue coverage, it gives you a bit of control. Yeah. Anyway, what the rest of you guys?
Sounds like a school night of mine, that.
Dominic?
Not really. I think Pete covered everything there, to be honest with you. So
was he?
Yeah.
No, yeah, I'd just say, for me, it's, like I said, I don't necessarily look at molar site or not. I look at the fact that if the bone's there and I can do it straight away, I'll do it. If I can't, I'll wait 3 weeks and then place it. So
yeah, I must admit, I've tried and failed at socket grafting. I must be rubbish at it, but direct socket grafting just doesn't work in my hands. The only time I do it is if I then cover it with a pedicle from the palate. If it's a very critical site, I'll take a pedicle and cover it, but I want primary closure basically if I'm socket grafting. But as I say, I think the protocol, as Pete would call it, is definitely the way to go. Do it 3 weeks later, even if you're not placing the implant. But then again, with the old squidge plant, you can quite easily just pop the implant into the EthOss and close it over anyway. So I
was trying to avoid saying that.
Yeah.
Yeah. Anyway, next question, Joe, because I see time is running by.
Yeah, so just the last 2 questions here. For an implant with peri-implantitis, with bone loss and pus, is there a protocol for usage with EthOss?
Bury it. I take everything off, allow tissue healing. If you can get the tissue to close over the top, leaving a small sort of dehiscence, then you're cooking on gas. You can then open it back up distant from the actual implant, repair the dehiscence, and then clean the granulation tissue off. And you can get back to, if you can get back to sort of bare bone and bare implant and treat the surface how you would treat the surface, whichever way you'd like to do it. You can then place EthOss, close it over the top. But the problem is that the patient, you'll probably get the bone back, but the patient is the patient, or the implant is the implant. And quite often, you may actually be better off just removing the implant and starting again, rather than going through all of that. I'm not sure, but quite often it's the patient factor. It's actually the implant position, or if it's above the ridge, or you've had ridge remodeling and it's all sort of stuck out of the ridge, then it's difficult. What do you think?
Yeah, so it's the factors of what causes an peri-implantitis, isn't it? And ultimately, once you eliminate those factors, because if you're going to just rebuild it, you're asking for the same problem to happen again. So I actually haven't done it with EthOss. I've actually just taken the implant out, let everything go, and we go back in and see why, and then replace the implant.
Yeah, I've done both, had success with both. It's host response, so you've got to just tell the patient they've got a poor host response, autoimmune response. But I'm just trying to do a couple at the moment. But I have one message to anyone out there: please don't send me any of them. It's a catch-22. No one. The only failing implant is the implant that someone else has placed. Then we just whip it out. But if it's our own implants, we're a little less, we always don't see the failure in our own stuff. But it's never the implant that's failing, it's the host metabolism that's failing. So we do need to look at multifactorial. I mean, that's why I don't ever bring it up much, because it's a whole day's talk and a debate and controversy and the possibility of being cancelled for a long time.
That's why I'd say, if you're doing immediate loading, always talk about nutrition with the patient, and vitamins.
Yeah.
And
vitamin D.
Vitamin D. I get my patients, I really talk to them about nutrition, and they really do need to get that up, and give it the best possible chance. And quite often, implant failures, I've had a full arch disappear on me, and it turned out that the patient just had zero vitamin D, basically. I mean, it's crazy. And I think it was Dom that really sort of highlighted that to me, the vitamins and things. So,
well, that was interesting that the two patients I've had with 2 failures each at the same site both had vitamin D deficiency, and then when I placed a 3rd time after we'd sorted the vitamin D out, it was fine. That's entirely anecdotal, I accept that, but both integrated with no problems whatsoever on a 3rd occasion at the same site. Just going to a different point, it's interesting if you're looking on the EthOss case studies page that both Chris Leeson and Tom Booth have recently treated cases of slightly different etiology, peri-implant disease. One Tom's case was a case where a healing abutment was lost during lockdown, and he cleaned and used EthOss to repair that. And I'd be very interested to see what happens with that. And Chris Leeson is using his laser as a treatment for the exposed threads on the implant before then going ahead with an EthOss build. And the 2 cases I've seen of his, obviously very early at the moment, but both loaded, look spectacular. But as I say, again, it's anecdotal and it's early days, but interesting.
Yeah, there's a long way to go and learn on this one. And I've been doing it for a long time, and it's the unpredictability. You can get something good, and then you get something not so good, and this is the reason why I sort of avoid talking about it. Shall we move on again?
Yeah,
Joe?
so the last question of tonight. Would you ever use a membrane over EthOss? I'll get you to answer that, Peter.
Look, you can use the membrane over EthOss, but if you're going to use, say, especially a reinforced one, you want to build something bigger, just make lots of really big holes in it, because I don't get around to using it much, membranes, but I've heard of people using cytoplast, but you make a lot of holes, because the research from a long way is that the bigger the holes, it's been known for many years, a lot of research on this, that the bigger the holes, the better the healing it's going to be. I mean, that's only natural. I mean, I literally haven't used a proper membrane for 20 years, so yeah, I'm not one to be talking about it.
For me, using a membrane with EthOss doesn't make sense, because EthOss is about true, bone remodeling, true host bone regeneration, and the concept of having a membrane would stop the process of angiogenesis anyway. So it would be counterproductive, surely, with using it with EthOss. So no, I don't use a membrane at all with EthOss.
I just use the patient's epithelium as my membrane.
Yeah, the periosteum. As they say, it's worked in trillions of cases over billions of years. If a double layer of pigskin was going to be the idea, we would have been born with it.
Yeah.
It's logical.
Honorific thought.
So yeah, I think that's all we've got time for tonight. So any questions we haven't answered, we'll get them answered via email and sent out to everyone over the next few days. But thank you, Dom, Peter, Mike, and Wasim for joining us, and thank you everyone else as well for taking the time to listen tonight. And
thank you guys.
Thanks a lot.
Thank you very much. Thank you.
Bye bye.
Bye-bye.